That's another excellent presentation, clearing out even more the situation for the inflammation and the eye rubbing. We have a couple of questions that I would like to discuss now. Maybe Damien can be with me. We have a question on the use of corticosteroid drops in allergic cases, and they ask if there's any evidence that we can contraindication of steroids with keratoconus. What do you want to comment, Damien, on that?
Yes, we use, if there is a indication because of local ocular surface inflammation, or if we believe that corticosteroids are a good adjunct to the therapy, and that's a cherry on the cake, but the cherry is bigger than the cake, have the patient stop rubbing, then we would use them. We regularly also use cyclosporine, topical cyclosporine, in some patients who have lots of allergies, and that also may be interesting for treating both the inflammation and sometimes the dryness of the eye. So I think it's a very nice armamentarium we have with this molecule as well. So we give patients everything from tears, local gels, ointments, steroids, and also anti-allergics, and cyclosporine.
Good, yeah. And there's a question of how quickly keratoconus can be escalated. I think certainly the allergy and the sudden has a cause, and the sudden development of keratoconus. Of course, allergy can escalate keratoconus, and eye rubbing can escalate keratoconus. This is something that has been proven and shown to you really elegantly. I don't think that there is any point of that. And there is the last question, again, I think is for you. How confident we are that eye rubbing causes keratoconus? I think we are very confident on that. And not some changes in the corneal collagen. Secondly, in what percentage can we say with certainty that eye rubbing is ultimately what causes keratoconus? And thirdly, does eye rubbing cause keratoconus, or does keratoconus cause eye rubbing? Okay, Damien.
Yeah, come on. I mean, for the last, I will start. That eye rubbing causes keratoconus is like you ask me if you press on something, this is the something which causes the pressure. I mean, seriously, when you interview patients, they rub way long before they have the first visual signs of keratoconus. So if you have a logical mind, and if you have a bit of proper thinking, I think in the most cases, because rubbing precedes keratoconus, the cause is the rubbing, and the consequence is the keratoconus. Now, the second point was in what percentage. This is where we disagree among keratoconus specialists. In my opinion, 100% of keratoconus is caused by some local repeated trauma. I always take the example of UV light and sunburn. I mean, there are risk factors like a light skin or going to the beach, but if there's no UV, there's no sunburn, there's no local trauma, there's no and a good argument for that is the Marfan syndrome. That's where I changed my mind, because as every one of you, when I was as a student, I was reading keratoconus, and I would agree on what it is. But the problem is that if you have a soft collagen, then Marfan is a case where you believe that the collagen is enough. You're wrong, because the soft collagen is the cause of the Marfan cause, flattening and thinning. Most inflammatory situation in the cornea without eye rubbing is causing not a thing, but usually a flattening of post-traumal inflammation, herpes, deciform keratitis, herpes zoster keratitis, scars. All these things, when you look at it, it's a flattening, not a stiffening and a thinning like in keratoconus, you see. So keratoconus is quite unique in its way. And because, and the first point was the change in collagen to me is secondary to the rubbing. And if you have one eye with keratoconus and the other eye has no keratoconus, anytime, every time there's unilateral keratoconus, there's unilateral rubbing, it's almost like an evidence of the mechanism in action. Because if you remove rubbing, that's what happens on the other eye, there's no keratoconus. So there's a lot of logic there, and it's difficult to prove scientifically like in mathematics, but I think I wish my contradictor come with a theory which from A to Z makes the cornea steep, focally thin, and deformed like it is in keratoconus. But it never happened yet, so I'm still puzzled by that. You muted, Miltus.
You have a good argument on that, and I have followed a lot in our specialist meetings this kind of discussion between you and other members, and I think it relies a little bit in the middle, and I'm more in favor of the mechanical the more I grow older and with more white hair, I think.
Yeah. What is important, because some people come to me and say you're stupid, because I know many people who rub their eye and they don't have keratoconus. Of course. It's like I know many people, they go to the beach, like in Greece, and they don't have a sunburn.
Yeah, I agree.
If you rub, you won't always have the keratoconus. But if you exceed some threshold, then you have it. That's my point. It's not bilateral, right? It's a unilateral relationship, causal relationship to me.
Well, if I may add, I think it's like the egg and the chicken concept. Sometimes after surgery, after cross-linking and corneal rings, the keratoconic patients, they admit they are rubbing less the eye. Of course, we have educated them, we have talked to them that eye rubbing is very bad. But I do believe that when we treat keratoconus and we decrease the protrusion, eventually the impact of the eye rubbing sensation that the patient has will be decreased somehow. So keratoconus, while it advances, like a vicious cycle that aggravates eye rubbing. So once we understand that, people that have the keratoconus treated, somehow they will have less eager to have eye rubbing. So it's very important that we understand this concept as well. So it's a kind of cause and consequence. And if I may add also, we have tacrolimus, which is a very important anti-inflammatory that gives you the ability to reduce inflammation with lower risk of glaucoma and cataract as we have with steroids. So it's interesting to have this on your armamentarium for clinical treatment, along with other anti-inflammatory like cyclosporin. And least but not less important is the riboflavin orally. So I'd like to ask you, are you using oral riboflavin, Damien and Mitos? What do you think about that?
Me, I don't use riboflavin even technically, because if I follow my theory, I don't believe cross-linking per se is the appropriate therapy, although I agree with you that when it makes the patient stopping the rubbing, it's good. So on that, I'm really happy that people have a good success with that, but I believe it's attributed more to the cessation of rubbing than the stiffening of the cornea. And I think that's important what you say. You have to break the vicious circle of inflammation leading to rubbing, leading to inflammation. And also there's sometimes less inflammation after some months after the cross-linking. And what has not been said is also to have an eye protection at night, to also break the inflammation, because we suspect that the role of the rubbing of the sheets, of the pillows, of the hands at night is probably a very important hidden causative factor for inflammation, etc. So having, in children especially, some like a
goggle
shields for night is quite interesting, and it helps sometimes patients to realize they rub unconsciously while they sleep, which is good also to realize. Do you use
the damage that you do with cross-linking on the corneal nerves play a role on the stop of the eye rubbing. Maybe they don't feel so much this triggering effect that they want to rub the eyes, or maybe we have passed the message best. We do use tacrolimus in off-label treatments, but unfortunately we don't have the tacrolimus from the Japanese, I think, drops from Sandoz. I don't remember. Anyway, we don't have these drops in Greece. We hope that we will have them in a year or two to come. And we don't have at the moment oral riboflavin to use at the moment. I don't know. I have no experience on that.
Yeah. One other thing that we have is the ability to improve ocular surface. So we have seen some patients that have done IPL, the intense pulse light therapy for dry eye. And I do believe if we do more treatment in the temporal area, we may have an impact on reducing eye rubbing. But this is still a hypothesis. We are starting to do some of these treatments to improve the sensation of eye rubbing along with the treatment for ocular surface for meibomian gland disease. So we have a lot of opportunities to tell people not to rub the eye and eventually to treat them for reducing the eager for eye rubbing, because eye rubbing is hard because people are really addicted to the eye rubbing. They feel very good. They feel pleasure with eye rubbing. So having people not to rub the eye is a complex situation, because you need to do a psychological. It's like being addicted to a drug. People have to be treated for that. It's not so simple and stop your rubbing the eye. It's a complex thing. So we have to acknowledge that eye rubbing is very important, and telling the patient not to rub the eye is not so simple.
Absolutely. We have another question on twins. Does anyone want to comment on twins and keratoconus? At least I have a few twins with keratoconus as a patient, but I don't think that necessarily when one of the twins has keratoconus, the other one will have. I'm not sure whether this happens on monozygotes, but certainly there are published papers with twins where one of the twin had keratoconus and the other didn't have. I don't know if anyone else wants to share any of these experiences on that.
We have a very good journal, the International Journal of Keratoconus and Aesthetic Diseases. This journal has a lot of good publications. Many of the publications that Damien shared in his talk were from this book, is this journal. And one of the articles we published there is a twin sister that came with a very asymmetric disease. And Damien has used this model for very asymmetric cases for demonstrating that the fellow eye with normal topography have some early changes on tomography, and now we have biomechanics, even wavefront can change you that. But the second twin sister was very interesting because she had both eyes normal. And both eyes normal, and then we would say exactly like that. So this twin sister demonstrate that this is not genetic. This is truly one of the ways of demonstrating genetic role in the disease. But interestingly, when you go deeper on the understanding of the disease, like the TBI in the four eyes of these four genes, the four eyes with the same genes, the TBI is abnormal, the tomography and biomechanical index, and this is published. So we are convinced that the first twin sister with a very asymmetric ectasia presentation, she has more keratoconus in the right eye because she rubbed more the right eye. The second twin sister does not have keratoconus. She has bilateral normal topography because she did not rub the eye, and that's pretty much consistent with their history. Interesting, we took the genes and sent to one of the companies that do genetic testing, and they pretty much concluded that they are twins. So that's the only thing that we have from the genetic testing. They proved that, they confirmed they are twin sisters. They have 99% of being twin sisters. So we don't have like a gene that is found somewhere, but those cases are the ones that we have to really collect. I have patients that are brothers and sisters, and one has keratoconus and the other does not. I have patients that had one brother and sister or sister had ectasia after LASIK, and we did PRK or LASIK in the other brother, and they are fine for 5-10 years. I'm sure Damien has the same, and you have the same experience as well. But this is definitely a multifactorial and combines the genes with the environment.
Well, we follow more than 20-25 families in the region. And what we see is that in some cases we have some members of the family with thin corneas, but no cone at all, and some other members with keratoconus. So I think thin cornea can be somehow a signal, and then someone will develop keratoconus, someone may not. And also we have some cases where we have coexistence of 2 or 3 dystrophies, posterior polymorphosis is one. Posterior polymorphosis is one that we see quite often. Cubes as well. And the other interesting thing is that we have 2 cases where they have macular dystrophy and keratoconus in 2 brothers. So okay, it's too complicated because there are so many factors, so many genes related to all these patients. But I think twins are crystal clear what's happening. And to answer the question, yes, not all the twins will have it. And there is another question about Massimo Lombardi's keratoconus. The cause of keratoconus might be fungal, and I think you want to discuss on that. Does anyone? I've been to just remember that he.
Don't rub your eye.
Sorry. Yeah, I mean,
don't rub your eye.
The question is, I cannot. After all this eye rubbing, I have to do something. But I think I'm too old to develop it. The question was not that aspergillus is the pathogenesis of keratoconus aspergillus. What he was mentioning was that during the embryogenesis, usually it resembles, aspergillus resembles the keratoconus in a sense that usually has does go into the thinnest location of the thinnest part of the cornea, and that's why he made the connection that it may be fungal, the cause of keratoconus. I think there is a lot of discussion. It's just another one of the theories that we have seen. I have to look it up, and I certainly cannot do that now. But if I can, I can try to answer tomorrow or maybe a bit so that's all I remember from this. Sorry about this. It's one of our doctors from the audience who asked that. So, Dimitris, let's move on and